Hello, and welcome to the Radiology Economics and Policy Learning Electronic Toolkit, Replete. This program was made possible through a GE Healthcare RSNA Education Scholar Grant from the RSNA Research and Education Foundation. I'm Rich Duzak from Emory University, and this module is another part of the series on physician payment systems entitled Bundled Payments. This module is targeted to Level 3 of the Diagnostic Radiology Milestones Project of the Accreditation Council for Graduate Medical Education and the American Board of Radiology. Milestones levels differ for the various ACGME-approved radiology training programs, and so if you are in a program other than diagnostic radiology, please reference the Replete resource webpage for mapping this module to the correct level for your individual program. The learning objectives for this module are as follows: to describe the ongoing evolution of physician payment reform initiatives to drive higher quality and lower cost care, to identify opportunities and challenges as physicians and health systems increasingly assume responsibility as well as risk for individual patients and populations of patients, and to outline various recent accountable episodic bundle payment activities that could impact radiology practices. In the last several modules, we have talked about the evolution of physician payment systems, moving from fee-for-service to pay-for-performance to accountable episodes. And we specifically talked about some of the nuts and bolts of fee-for-service and some of its attributes, as well as some of its many unintended consequences. We also talked about the recent proliferation of pay-for-performance initiatives, all still works in progress, and how at least some of these could result in unintended consequences as well. In this module, we'll focus on bundle payments for accountable episodes of care. This represents the goal of many health policy activities, all intended to incentivize providers and health systems to improve quality and reduce costs. Accountable episodes are in many ways synonymous with bundle payments. That means you get a single bundle of dollars for a defined episode of care, regardless of how much you do or how little you do, as long as you meet certain quality and outcomes thresholds. These initiatives are designed to put financial skin in the game for providers and health systems to move even further up the illustrated quality and cost staircase continuum. Here are some additional resources listed alphabetically by author for those who would like to learn more about the topics in this module. Our country's health system is at a crossroads, with a delivery system that has historically been paid for volume rather than value. As we talked about in the fee-for-service modules, care is incentivized to continue down the volume highway, full speed ahead. All the while, CMS, private payers, and a variety of policymakers have for years tried to direct traffic, encouraging providers and health systems to stop and turn down another road, to no avail. Simply saying stop, however, hasn't worked. Healthcare, like most other industries, follows the dollars. And so waving dollars instead of stop signs is believed by many to be the solution. With the right incentives, so most of us believe, we can increasingly steer care to become more value-based rather than purely volume-based. To date, most initiatives in value-based care have focused on primary care and coordinating services in what some refer to as medical homes. In medical homes, each patient's care is housed in the domain of their primary care physicians, who ideally work with specialists as necessary so that everybody is rowing in the same direction in the interests of their patients. This primary care focus is the basis of many accountable episodic bundle payment initiatives to date. But how these bundle payments can apply to specialist care is unclear. And even less clear is how these could work for referral-based physicians, particularly radiologists, pathologists, and anesthesiologists, who typically provide their services in conjunction with clinical partners, who most of the time are the ones driving the care pathways. For those of us who work in radiology, health policy research, and those who work in specialty advocacy, that makes our tasks much more daunting. But given that little work has been done in this space, it also creates immense opportunities for our specialties leaders to really move that needle and make sure that our needs and those of our unique patients are appropriately considered. For those who are just beginning their careers, or those who haven't been in the wonky weeds of payment reform initiatives, this is even more daunting. My hope today is to provide some guidance on how to start thinking about these issues that will increasingly impact our practices. In this module, we'll start with some basics, definitions, concepts, and prototypes, and I'll outline for you some tools that are emerging for leaders at both the practice and broader specialty levels, many the work of the Neiman Health Policy Institute. Tools that you can start using today to help with your learning, scenario planning, and decision making. First, let's start with some definitions. When you talk about accountable episodes and bundle payments, you'll often hear folks talk about alternative payment models. Just what does that mean? It really just means new types of payment models. We've spent a lot of time already talking about old payment models, and by that we mean plain old fee-for-service, or as I'm indicating here in my unofficial abbreviation, POFFS. In the last couple modules, we spent a bit of time talking about one subtype of new payment models, pay for performance. For physicians, when we say pay for performance, we're typically talking about Medicare's evolution from PQRI, the Physician Quality Reporting Initiative, to PQRS, the Physician Quality Reporting System, to MIPS, the Merit-Based Incentive Payment System. In this module, we'll be talking about accountable episodes. Under the recent macro legislation, which will be the topic of an entirely separate module down the road, pay for performance will be largely synonymous with MIPS, and accountable episodes will largely be synonymous with advanced alternative payment models. Note the second A there. APMs generically refer to anything that's not plain old fee-for-service. AAPMs, the extra A meaning advanced, usually refers to accountable episodes where providers and health systems assume financial risk. And the reimbursement for an accountable episode is typically a bundled payment. What then is a bundled payment? In a bit of a circular definition, it's a single, comprehensive payment for an episode of care. That, of course, begs the question of what is an episode of care? In short, it is the services rendered to a patient during a defined period of time for a defined purpose. The word that I think is most important to understanding what episode of care means, though, isn't even in that definition. It's the word risk. When you hear the word accountable as it pertains to anything in healthcare payment systems, what you should think about is the assumption of financial risk. In many ways, we're asking dollars and health systems to act in some ways as insurance companies. And so the analogy of an auto insurance policy is appropriate. Here's the insurance card for our family's old Ford. I paid State Farm for that policy. And in issuing that policy, State Farm has assumed certain financial risk for that car. But that risk is not without limits. The policy starts on a particular date and ends on a particular date. And it applies to only a specific car, the one my kids drive, not the one I drive or the one my wife drives. And it only covers certain things at certain amounts. For example, we've agreed upon a deductible of $500. And that's how I'd encourage you to think about an episode of care as well. An episode of care has a specifically defined starting point and a specifically defined ending point, just like my insurance policy. And we define up front what's included. That is, what's the deductible? Does it include a rental car, or in the case of healthcare, preventive services, or out-of-network benefits, or whatever? When healthcare entities assume risk, they need to know what specific risk it is that they're assuming. And so, like my car policy, an accountable episode doesn't go on forever or cover other things that we never agreed upon, say oil changes. What makes this all tricky is figuring out who decides that green box and who decides that red box and who decides what's in the middle. To date, this has largely been done by the Centers for Medicare and Medicaid Services, CMS. And that's why, I think, that these models have been seen as bureaucratic and unwieldy. That's why we'll pivot in a few minutes to opportunities when providers and health systems, rather than the government, craft the terms of episodes and bundles. As I indicated, to date, most bundles have focused on primary care, and in the few that exist for radiology, have focused on the technical side of things, and for inpatient care in particular. In a very early module on teaching physician rules, and a more recent module on the professional versus technical payment divide, we talked about the different ways in which facilities and physicians are paid for inpatient care. Inpatient care is really a nice model for bundle payments because it has a defined starting point, that's the admission, it has a defined ending point, that's the discharge, and clarity as to what's in the middle. That's pretty much everything that happens in the hospital. As we talked about, hospitals get a single bundle payment from Medicare for each admission, based on a diagnosis-related group, or DRG. If they use fewer services and get patients better and out of the hospital faster, they still get the same amount of money as if they used more resources. So they're incentivized to reduce costs and maintain quality. Physicians, on the other hand, are paid under plain old fee-for-service. The more they do during that hospitalization, the more they get paid. So the incentives of these two very different stakeholders are not entirely aligned. And that's the goal of some early bundle payment initiatives by CMS. Under the Comprehensive Joint Replacement Bundle, which is currently on hold by CMS for some political reasons, there is essentially a big single bucket of money that goes to the hospital. And so that hospital is incentivized to make sure that its doctors are all providing care in a coordinated and aligned manner. Remember, there are different buckets of money for physician and hospital fees. But in reality, the care provided by these two groups is not separate. Physician services can dramatically influence hospital costs since doctors decide what tests and procedures get ordered and when patients get discharged. This lack of alignment has contributed to the huge waste in the U.S. healthcare system. That waste has been estimated to be as much as 1/3 of all healthcare dollars spent. I'm not sure if that 1/3 amount is right or not. It sounds like a lot to me. But even if it's inflated by 2, there's probably at least 15% in waste and inefficiency dollars that could be recycled. The goal then is to turn that waste into savings by having doctors work with their hospitals and have everyone share in the savings of that new slice of the pie. More money back to the hospitals for working more closely with their doctors. More money back to the doctors for working more closely with their hospitals. And importantly, more money back to patients who we know from prior modules are paying huge amounts of money under current high-deductible plans. This isn't just hypothetical stuff, although at present it's been put on hold, and hence the asterisk in my title. CMS has implemented a single bundle payment price for elective hip and knee replacement surgery back in 2015. It was rolled out in 2015 in 67 markets across the country. And if you look closely, you'll see that 8 of those 67 pilot markets are in Florida. Why Florida, you may ask? Well, remember my U.S. heat map from a few modules back. In which state was healthcare spending the highest? It was Florida. So CMS is chasing the money, trying to selectively trim what it sees as unnecessary fat out of our healthcare delivery system. If you're interested in inpatient bundle payments, I encourage you to go to the Neiman Health Policy Institute's website and play with some of the scenario planning tools that group has developed. If you look, for example, at which DRGs have the most episodes across the country, interestingly, you'll see DRG 470. That's the DRG for hip and knee replacements at the very top of the list. And so it's no surprise that CMS launched its first inpatient bundled initiative in that space. Just like Willie Sutton, the famous bank robber, when asked why he robs banks, his answer, of course, that's where the money is. Let's pivot now to the future, uncharted territory in which radiologists have the opportunity to lead episodes of care, getting reimbursed in a bundled manner. We'll focus on the outpatient setting. Remember the key points of an accountable episode. It has to have a clearly defined beginning, it has to have a clearly defined end, and it has to have a clearly defined middle. Imagine the opportunities if we as radiologists were defining those parameters, rather than waiting for the government to do it for us. And hope that they know enough about what we do to get it right. Let me share with you then some work that the American College of Radiology and the Neiman Health Policy Institute have been doing in this domain for the last several years. There's a lot of traction and progress in using screening mammography as a prototype for an outpatient imaging bundle. If you think about it, what happens downstream to a screening mammogram is usually related to the interpreting radiologist's recommendations. And so, working in a collaborative manner, we've been crafting a bundle that starts with the screening mammogram, ends some 364 days later, that is, at the time of the next annual screen. and it includes all the breast imaging that happens in the middle. That means no invasive procedures and no cancer treatments. There's some wonky reasons for that. So, for a single bundle price that is determined in an actuarial manner, the episode includes all imaging between the green start and the red stop. Whether it's add-ons to the base screener, such as CAD or digital breast tomosynthesis, a follow-up, when necessary, with diagnostic mammography, which might include CAD and/or DBT. It might include ultrasound in some cases, and even in rare cases, MRI. Under this model, a patient or her insurer would pay just one price up front, and all of these services would then essentially be included if necessary. It's effectively a transference of risk from the insurance company and the patient to the radiologist and/or the health system. And so it puts financial skin in the game for radiology practices to use follow-up imaging more judiciously. And since there are no costs to the patient for follow-up studies because they're all actuarially included in the bundle price, it may actually help improve patient access, knowing that some women unfortunately do not undergo screening mammography for fear of the high costs associated with the not uncommon follow-up studies that occur downstream to that screener event. I won't go into all of the wonky details, but this econometric model, published by Dr. Danny Hughes, indicates that this is all quite feasible and sufficiently substantive and robust that discussions are now underway about piloting this in real clinical environments. So stay tuned. The nature of how we as radiologists get paid for one of the most common examinations performed in most of our practices, that is, screening mammography, could potentially be changing quite substantially. This could put our specialty into the driver's seat of coordinating care and helping our health systems navigate the new financial world of healthcare reform. And just as with inpatient episodes of care, if you're interested in the concept of radiologists driving bundle payments in the outpatient setting, I encourage you to go to the Neiman Health Policy Institute's website and play with another one of the scenario planning tools the group has developed. There's an interactive tool there that will let you see the overall population costs associated with higher or lower screening mammography callback rates, as well as recommendations for follow-up ultrasound and MRI downstream to a screening mammogram. These are interesting times of change in how physicians and healthcare systems deliver care and how they get paid. As I indicated at the beginning of this module, most interest in advanced alternative payment models, AAPMs, to date has focused on outpatient services by primary care physicians. But the fact that payers aren't pushing alternative payment models in imaging right now should not lull us as radiologists into complacency. That current void represents an opportunity. You can read here the opinions of some forward-thinking health policy experts. This is a time when we as radiologists need to embrace evidence-based advocacy and support our specialty societies through both our membership dues and our volunteerism. It is all an investment in our future and the future of our patients. And finally, a few words of caution. I outlined for you a number of unintended consequences previously of fee-for-service that led many policymakers to advocate for new payment models. I specifically outlined for you some of the problems that we're now beginning to uncover with emerging pay-for-performance programs. In this module, we've talked about advanced alternative payment models, accountable episodes, and bundle payments. These are all theoretically quite attractive, but probably also not immune to the downstream unintended consequences we've seen with other payment models. Some recent work that you see highlighted here from JAMA Internal Medicine indicates that early bundle payment initiatives may not be performing as well as many had expected and hoped. So, we all have some more work to do. In summary, physician payment systems remain in evolution. Despite its various problems, traditional fee-for-service isn't going away, at least not yet. But alternative payment models are becoming increasingly relevant. Understanding emerging incentives for higher quality and lower cost care will help radiologists better adapt to our changing healthcare delivery system and the economic environment in which we all practice. To ensure appropriate credit for this module, please make sure that you complete the accompanying online quiz from the RSNA's e-learning platform. More information on the Replete initiative and additional resources are available on the RSNA's website. I'm Rich Duzak from Emory University, and I look forward to helping you continue along your economics and health policy milestones journey. Again, thank you for for participating in Replete.